Good afternoon, and welcome to DePaul University's online Certified Financial Planning Certificate Program. This is the introductory class for Introduction to Financial Planning and Insurance Planning. This is the replay for session 11, which is unit number 9. The agenda tonight is we're going to be going over a few items where we had some emails and questions for unit 7. And then we're going to get into healthcare, the Affordable Care Act, disability income, long-term care planning, and I'm going to break it up so you'll be able to listen when you need to. Starting with slide number, I think it's 53 in Unit 7, talks about non-forfeiture values. Non-forfeiture values, ladies and gentlemen, deals with primarily whole life insurance where there's guarantees and limited payment life insurance. And what it says here is we are going to guarantee and know how much cash we have in the contract, how much insurance we paid for in any given year in the contract, and if we want to maintain it either as a reduced paid up policy, that's what we paid for, or turn it into a term contract, how does it work? So on this slide, non-forfeiture options, assuming a $50,000 face amount. Let's go down to line 10, policy year 10. It says, and these are hypotheticals, it says we have $99 of cash in the contract for every $1,000 of insurance. So in this example, you would take 50 units of insurance, multiply 50 times 99, that would be the amount of cash you have in the policy in the event you want to stop paying the premium. If, on the other hand, you want to have a reduced paid-up insurance policy, you're willing to have less than $50,000 of face amount or death benefit, and you never want to make another premium payment, that $99 per unit or per $1,000 would convert to $222 in this example of death benefit. So you'd multiply 50 times 222. That would give you the amount of life insurance you've paid for. You will never have to make another payment, and the policy would be in force until the day you die. If, on the other hand, you wanted to stop making the premium payment and you wanted to turn this into a term contract, the question is how long would that $99 times the 50 units of insurance keep the term insurance in force? And it says here 23 years, 116 days. So that's what you've paid for at that given time. If you wanted to look at age 65, you would have paid for more cash, you'd have a larger amount of reduced paid-up insurance, and a longer period of term insurance. The reason I'm going over this again is some people sent me some emails asking for clarification, but I also want you to be aware of the fact that on my comprehensive exam, there was a question that asked you to compute that. So the next slide is assuming you have the same information on the previous slide. And I want to, oops. Ooh, that should be 75, I'm sorry. This next slide is an error. That should be 75,000. So on the next slide, let's assume for a minute it said 75,000, and that's what's in your workbook is 75,000. Then do the work and figure out how much cash is in using the numbers from the previous slide. You can fill in the blanks yourself, and that'll tell you. So it's either 50,000 or 75,000 as long as you understand the process. Now, the other thing that some people sent some emails about was the taxation of annuities. And if you remember, again, this is from Unit 7, annuities are taxed on a last in, first out basis. The gain on the annuities is not part of capital gains. It's not subject to capital gains tax. It's always subject to ordinary income tax. Now, annuities can be either in a qualified plan, such as an IRA, a 403B, or 401k, or they could be in a non-qualified plan. If they're in a non-qualified plan, the money as it goes in is what you've put in first, but the money that comes out is what the gain is. So that's going to be taxed at ordinary income tax rates, last in, first out. If the money is coming out of a IRA or 403B or 401k, everything is always going to be taxed at ordinary income tax rates. If you take the example here of Mel had $100,000 in the annuity. That was his basis, and he took out $250,000. It's now worth $250,000, and he's 62 years of age. He wants to take some money out, and it says anything that he takes out over the basis, which is up to 100, which is the basis is 100,000. So the first 150,000 he takes out would be treated at ordinary income tax rates, not subject to capital gain rate. And if he's under the age of 59 and a half, there's also a 10% penalty. The next slide talks about the taxation of partial withdrawals. Paul is 58. He invested $100,000 into his non-qualified annuity, and it's now worth $200,000. He wants to take out $150,000. At age 58, the first $100,000 he takes out is considered earnings. He's taking out $150,000. However, he put in 100. That's his basis. But the rule says the first money coming out is your gain that you're going to pay ordinary income tax on. So that's why the first $150,000 he will pay income tax, ordinary tax rates on the $100,000. Plus, since he's under 59 and a half, he's going to have to pay the 10% penalty. That's why it says and the premature tax. The next slide talks about annuitization. And it says if the contract is annuitized, that means we're turning it into a lifetime income or an income over a period of time. Part of each payment is considered to be return of principal. This is for a non-qualified annuity. Again, not part of an IRA, not part of a 403B or a 401K. It's a non-qualified annuity. And it says part of each payment will be treated as return of principal. That means you've already paid income tax on the money. You're not going to be taxed on it a second time. You will owe income tax on that part of the payment that is the gain. And how do you figure that out? It's called the exclusion allowance or exclusion ratio. Now, in the real world, the insurance company is going to compute that for you, and you're not going to want to do it because you're not going to want the liability that if you made an error, you're going to have to pay the Internal Revenue Service the fee for the error for your client. But in the world of the exam, you need to understand how to do this formula to do this calculation. That's what the next slide shows us. Art had a fixed annuity there. He invested $100,000, and he's going to take a $750 per month benefit, income per month for the rest of his life. He's 62 years of age. According to the IRS life expectancy table, which is the one that all the insurance companies will use, it says Art's going to live 22 and a half years. That's what this says right here. He's expected to receive payments for 22 and a half years. So how do we figure out the exclusion? He started with $100,000, and if he's going to get $750 per month times 12 times 22 and a half years, that's going to equal $202,500. We then divide the $100,000 by the $202,500, which is his total amount, and that will determine that the exclusion ratio is 49.4%. So out of the $9,000 Art's going to receive every year at $750 per month, he can exclude $4,446 from his taxes and pay tax on $4,554. That's the advantage of having an annuitization payment on a non-qualified plan, because you can take advantage of lower taxes. However, the next line is very important, especially for the examination. It says, if Art lives beyond his life expectancy, he will have spent his entire basis. Therefore, what's going to happen? All the money coming out will be taxed at ordinary income tax rates. This next item I just want to make sure you understand, because it can be tested. And what does it say here? It says, as a general rule, deferrals of undistributed income is not available to entities that are a non-natural person, which would mean a corporation, certain trusts, certain other entities. If it's a personal trust or a living trust, that's going to keep the exemption, but otherwise it probably won't. What that means is, if somebody uses an annuity for a deferred compensation program or as an executive bonus program where the corporation owns it, they don't get the tax deferred growth every year. They have to pay tax on that money. Now, the comprehensive exam likes to ask questions on taxes, so I want you to be aware of the fact that when you study for the exam, pay attention to the phase-ins and phase-outs for Roth IRAs, for qualified for deductions of qualified plans, for the money for college savings, and so forth. And it says that if you have an annuity owned by a corporation, the internal buildup will be subject to ordinary income tax. Please also remember from Units 7 and 8 that last in, first out is what is used for taxing for most annuities and modified endowment contracts. First in, first out is for life insurance. Remember the rules because you're going to be tested on them. And when something becomes a modified endowment, it's always a modified endowment, and the money coming out during your lifetime as a living benefit for income, for a loan, to help your child go through college, whatever, that would be taxed at ordinary income tax rates on a last in, first out basis. I'm going to take a 2-minute break. This reviews the information that people have asked for. So I'm stopping the recording for a minute. Welcome back to the class for the 5th of March. This is the replay that I'm putting together on medical expense insurance, which will also include the Affordable Care Act, disability income, and long-term care insurance. The information I'm giving you is to the best of my knowledge what's accurate and correct regarding the Affordable Care Act or the Patient Protection and Affordable Care Act. It has been gleaned from the internet and from multiple sources, but I will be honest, I have not read the 2,500 plus pages of the law myself. The information has been found to be in more than one source, and I also want to let you know that I'm not making any political judgment regarding whether it's a good law or bad law. I'm telling you what you need to know for the course. I'm also telling you that when you go to take the comprehensive exam, ask the review instructor what's currently being tested. You will not get any test questions or quiz questions for this course on this information on the Patient Protection Act or the Affordable Care Act or Obamacare, however you want to phrase it, but you need to understand it. And advisors are more frequently being asked questions on health insurance and long-term and Social Security and Medicare insurance. So what you have to be aware of is to your advantage to know this information. The information can readily be found at the www.healthcare.gov website. And it's a confusing website. I've been there. But you also have to be aware of the fact that there's a lot of information. It's changing. Just this week, the government said that they were not going to be enforcing for the next 2 years individuals that had in their own plans as individuals, that they were going to defer that a little longer. And also be aware of the fact that there's a lot of controversy whether the website itself is secure when you're putting up your Social Security numbers and other information. The goal of the law, according to the authors of the law, was to provide full insurance to the 15% or approximately 35 to 40 million Americans that didn't have insurance, and to also provide for 10 important facets that all policies have to have, including no pre-existing conditions. Now, there's a lot of controversy between the law in terms of who's paying for what. And again, what I'm giving you is to the best of my ability as of the middle of January to update the information. The law says that everybody has to have coverage. The law says that they will subsidize coverage for low-income individuals. And they're defining low-income individuals as those people whose income is at the federal poverty level times 138%. So even if their income exceeds that number of poverty, if they're still within that 138%, they are eligible for subsidies. Sometimes, and some businesses are going to be getting tax credits for providing insurance. and the government is set up at different states, many places that have health insurance exchanges, and you have to have an ID card that you carry with you to verify you have coverage. Where it says there's lots of confusion, which means there's opportunity for planning, there is a lot of confusion, and some people are very frustrated by it. In terms of the health insurance exchanges, some of the states have opted out and don't provide them. Some states have them. Some states are telling you to use individual insurance companies. Others are saying use the companies or come to us. So depending on where you live, pay attention to what's available. And I'm going to tell you it's very confusing. The law says that every American has to have health insurance or pay a fine. The law further says we're expanding coverage to young people who are still living with mom and dad or still in college to the age of 26. It used to be till you were out of high school. Then it got to be age 22 if you were a full-time student. Then it became age 24, and now it says age 26. It says that insurance companies can no longer prohibit or deny coverage if people had pre-existing conditions. And this is very important because what people didn't realize is, until it was too late, that if they had heart conditions, they were overweight, they were diabetic, they had cancer, leukemia, or any one of a number of issues, if they were trying to buy individual insurance after they had these problems, they couldn't get them as an individual. Many times they had to go to the state plan that was available that was to help people that could not get insurance, but many states, such as Illinois, had maximums of what the budget would allow them to have, and people were put on waiting lists so they had no insurance. The law says you can no longer have maximums either per year or lifetime maximums for your coverage. Every plan now has to have full coverage for your lifetime with no maximums. It says you can, the insurance companies, once they issue the plan, they have to keep the plan. They can no longer rescind it. The law further requires that, again, federal subsidies have to be provided for low-income people, and if they can't, if their income is so low or they have no assets, they will fall under Medicaid. The law says that there will be state and federal exchanges that are work jointly. Illinois has a joint exchange with the federal government, and tax credits will be available to small business owners in order to provide the coverage if they haven't provided coverage previously. The federal government says that if you have a corporation or a business, no matter how it's a company, whether it's a corporation or a sole proprietorship, it doesn't matter. If you have more than 50 employees, you have to provide health insurance coverage or pay a fine. You can get more information by going to the healthcare.gov website for all kinds of updates. And I'm telling you right now, you need to go there before you tell anybody definitively what's going on. The law is going to require that companies provide for immunizations for children and cancer screenings for women. Very important coverage and points that people have to be aware of. The state of Illinois, in all of their health insurance plans, offered health insurance screening for women for several years if people were buying the coverage or on extended coverage in Illinois. It requires preventive care. Up until this law, many times people would want to be going for a routine physical, and if they didn't say that they had stomach issues, they were not feeling well, they couldn't sleep or whatever, their health insurance policies wouldn't cover them for routine physical. Now they have to be covered. Maternity will be covered the same as any other medical condition across the board. Newborns will be covered automatically. And there'll be certain pediatric care that has to be afforded, as well as tests, immunizations, and well baby care. Emergency room coverage and hospice care, laboratory tests, mental health benefits, substance abuse benefits, and then again, prescriptions and expansion of Medicaid. These are what's called minimum essential coverage. Some people are upset about it. Other people say it's great. Again, it's a value judgment depending on how you want to look at it. What we also know in the law is there's 19 new taxes, fees, and penalties that have been included. The law is saying that you should be able to pay 9.5% of your income for health care as a family. It says that we've expanded Medicare and Medicaid. It further says in the law that if you have what's classified as a Cadillac plan, and a Cadillac plan is someone currently who's paying more than $10,000, I think it's $400 for a family, and has broader benefits than the average, you're going to have to pay income tax on the difference of what that plan cost and what the government says you should have. So if you have a better plan and your employer is providing a better plan, now you're going to be paying income tax on that extra income. And now that is causing some people a lot of consternation because they're going to pay it, and the unions, just so you know, have an exemption until 2018 on that tax. The law further says that there's going to be a tax on tanning salons and tanning services of 10%. There's also a tax now on prosthetics and other medical devices. And there was just a news story on, I think it was CNBC or Fox Business, that discussed a company that only does medical devices and prosthetics for children, and they said the new sales tax that they're going to have to pay might put them out of business because they can't pass that along to their consumers. There's going to be an additional tax on restaurants and food sold from vending machines and help to pay for this. And the fines and penalties would be up to $44,000 per person or per employee, and in many cases at $2,000 for the employee that the company has to pay is actually less than they're paying for health insurance, so some companies may stop offering health insurance altogether and just give people more money. Most people are going to find higher deductibles, higher out-of-pocket expenses, and higher premiums. It shows here that you can be a family of four making $94,200 a year and you'll still be eligible for some kind of subsidy for health insurance. According to what I've read, what you're also going to find is that health savings accounts, which we'll be discussing in a few moments, will provide more information and probably provide more coverage, because people are going to find that they can take a higher deductible, get deductions, set up their own health savings account, and save some money. But the current regulation prior to January 1st said if you took money out of your health savings account for anything other than medical expenses, you're going to be subject to a 10% penalty. Now that penalty goes to 20%. This is the end of the information on the Affordable Care Act. Again, you're not going to get any quiz or test questions on it. I'm going to stop the recording for a second and then get into the material for tonight. Welcome back. Medical expense insurance. The material I'm going to cover now will be on quizzes, will be tested on your final, and I know will be tested on a comprehensive exam. As a risk management tool, people that don't have health insurance are playing Russian roulette, because the cost of catastrophic economic losses is huge in our medical environment today. It is not uncommon for newborns that have issues, medical issues, in the neonatal intensive care areas to be charged $20,000 to $30,000 per day for care. It's not uncommon for people to have $10,000 to $20,000 of care in intensive care areas. Now, so as a financial planning risk management tool, we need to understand about some health insurance issues. Traditionally, a lot of policies had low limits, and most people that had health insurance after World War II, they would have a policy that was called an indemnity plan that might pay $25 or $50 a day in hospital. It would have a schedule for surgical benefits. It would have other maximums. And if you notice here, there are limits. It even has, this wouldn't have been in the 1950s, but it shows $5,000 for a heart bypass. Those are low limit plans. Then, many times, in addition to the lower limit plans, people would say, okay, my current plan covers $25,000 or $50,000 worth of expenses. After that, I'm going to superimpose a supplemental plan for medical expenses, and that actually became the forerunner of what's called comprehensive major medical today. Because today when you buy a plan, for the most part, you're buying a total package that's going to cover in-hospital, out-of-hospital, patient care, doctor's visits, surgical schedules, and it's all in one plan. So what it's doing is it would take the lower limits and the larger limits for the catastrophic situations and give you one large plan for that. The comprehensive major medical plan has certain terms that you need to be aware of, and you have to make sure you review them and understand them. You will not be getting test questions that said, what is the definition of this or the definition of that? You will be getting questions to see if you understand how it works. So a deductible is the amount that you are paying out of pocket first. Sometimes you have a family deductible, which means it might be $5,000 for the whole family. Most of the time it's a deductible of $250 to $1,000 per person, with a maximum of three or four per family. So the deductible is what you pay first. After the deductible, there is what's called a co-insurance percentage. That's what people typically refer to as 80-20, 70-30, 50-50. And that percentage means some of the money is paid by the insurance company, some of the money is paid by you, the individual, the policyholder. So here it says co-insurance is 20% by the insured, that's you, 80% by the insurance company. It further says that once the insured pays the deductible and the co-insurance percentage to what's called the break point, the insurance company will pay 100%. So be aware of deductible, co-insurance percentage, break point, and then that'll give you what's called the maximum out of pocket. Now, not every policy uses these terms the way we're using them for the exam, but these are the terms that you need to be aware of. Deductible. Stop loss is technically the dollar amount that the co-insurance percentage is based on. So this is not rocket science. If the stop loss is $5,000 and you're responsible for 20% of that $5,000, you're responsible for your deductible plus $1,000. If it's 20% of $10,000 to the stop loss, you're responsible for your deductible of $500 plus $2,000. If the policy says that it is 70% to the insurance company and 30% to you, to a $10,000 stop loss, then you're responsible for $3,000 plus your deductible. The lifetime maximum is one of the items that is going away in the new law, but currently many people still have them, which means that you have $1 million or $2 million or $5 million benefit. Your deductible plus the co-insurance percentage to the stop loss is your maximum out of pocket, MOOP. And that's what most people are concerned about, is the maximum out of pocket. Your co-insurance percentage, I've already explained, and some policies have what's called an office visit copay. Now, let's look at this example to see if we can make some sense of it so you have an idea of what you're looking for. It says the co-insurance example with a stop loss. This is slide 18. Our client has $1 million coverage with a $500 deductible, 80-20 co-insurance to a stop loss of $10,000. Let's assume there's $20,000 in medical expenses. Our client, the insured, pays the first $500, and you'll notice that the insurance company pays $0. You, the client, are on the hook for the first $500 out of pocket. Then the co-insurance percentage is 20% for the insured, 80% for the insurance company of the next $10,000. So for the next $10,000, you, the insured, pay $2,000, and the insurance company will pay $8,000. Over the stop loss, which is the $10,000, you, the insured, pay $0, and the insurance company will pay $9,500. 2,500 plus 17,500 equals 20,000. But remember, the stop loss is the amount up to the co-insurance percentage, and the next point is the deductible is paid first, and then it's of the next $10,000. The third point you have to be aware of is, in this example, on a $20,000 bill, you're paying a higher percentage than if the bill was $200,000. If the bill was $200,000, you'd still be, your maximum out of pocket would still be $2,500. So the way this is designed is on smaller claims, smaller bills, you're going to pay more money, a larger percentage. On larger claims, larger bills, you're going to pay a smaller percentage. So this is what's called co-insurance with a stop loss. If you get a test question on it, you might get a test question that says, Jack, in-network is a $500 deductible, 80/20 co-insurance to a $10,000 stop loss. If he's out of network, it's a $1,500 deductible, 50/50 co-insurance to a $25,000 stop loss. Once you read the question, it's going to say whether the claim is being done in network or out of network. Once you know if it's in network, only focus on the numbers for in network. If it's out of network, you're going to have to focus on the numbers for out of network, but not in network. Why am I saying that? Because on the comprehensive exam, ladies and gentlemen, it's very prevalent that they might ask you either way what's going on. So they might say they're going to give you the information. They might have the answer for each set of information, but you only need to know if the question is being asked for in network or out of network. Here's another example with a $90,000 bill. And again, it's the same situation, same deductible, same co-insurance percentage, but here you're only paying $2,500 and the insurance company pays the balance. There's an out-of-pocket example. More and more insurance companies are saying you have to now spend out-of-pocket a total of $5,000 or $10,000 before we pay 100%. So in this example on slide 20, Gwen is covered under a major medical insurance plan with a $300 deductible, 80/20 co-insurance, and she incurred an $8,000 covered medical expense bill. But the insurance company only absorbs 100% once Gwen spends $5,000 out of pocket. If that's the kind of question you get, this is how the example works. And I'll tell you right now, on a quiz in this class, you're going to have both examples, and on your final, you're going to have both examples. So make sure you understand it. The deductible says you pay the first $300, the insurance company pays $0. Now that leaves $7,700 left. You're going to pay 20%, the insurance company is going to pay 80%. So you will have paid a total of $1,840 on this example. The next slide has a similar example, but now the bill is $38,000. Here you will have maxed out your $5,000 out-of-pocket expense. Once again, these are two different kinds of claim examples. Expect to get both of them on a quiz and on your final exam. Many people are able to buy insurance, and these are technical terms, and I'm going to say this because I'm going to review these terms again under disability income and long-term care. You can get a health insurance policy that's non-cancelable, which means the insurance company cannot change the premiums or change any of the underwriting or do anything with that policy as long as it's enforced and you pay the premium. I don't know of anybody that has a non-cancelable health insurance plan today. Most policies are guaranteed renewable, which says the insurance company will guarantee to renew the premium that is currently in force for you or your age bracket as long as you pay the premium. They can't single you out as an individual, and they can't say because of your claims they're raising the premium. But if they raise everybody in the state of Illinois, or as your age bracket goes from 44 to 45 and they can raise the premium based on that, that's called guaranteed renewable. Conditional renewable, I don't see many plans like this, and I honestly can't tell you when was the last time I saw a plan like this, but it says we have the right to make some changes at renewal whether you like it or not. Currently, This is important for you to remember because it has to do with medical insurance and with Medicare and Social Security. Slide 23. People that are on a salary or earned income are responsible for paying FICA or Social Security tax on the first $117,000 of their earned income. In addition, they're going to pay, as an employee, 6.2%, and the employee pays 6.2%, the employer pays 6.2% of that total number, for a total of 12.4%. If you're self-employed, you're paying the self-employment tax, which is all 12.4%. In addition to Social Security or FICA tax, you're paying a 1.45% tax for you, and another 1.45% or 2.9 total between you and your employer for Medicare. And there's no cap on Medicare. And that means that when you figure out on a quiz question or a test question and you look and see, you're going to see that the Medicare tax, sometimes they're going to have the tax to see if you can remember that FICA has a cap to $117,000. Medicare has no cap. So if you're making $300,000 or $400,000 under Medicare, you're paying at least 1.45% for you and for your employer, another 1.45%, unlimited on income. Under the Patient Protection Affordable Care Act, there's now an additional success tax for Medicare of 0.9%, bringing the total Medicare tax to 2.35%. If you're earning over the thresholds that are currently listed at $200,000 for an individual and $250,000 for a family. Again, this is one of those phase-in, phase-out questions. So let's look at slide number 25, and we'll get an idea of what we're paying. If you're making $150,000 a year of income, in 2014, you're going to pay 6.2% as the employee on the first $117,000, plus you're going to pay 1.45% on the entire $150,000 for Medicare. So you're paying $9,429. Your employer matches that. They're paying $9,429. Therefore, you're at a total of $18,858. If you're earning $350,000, this is what you're paying in taxes. Slide number 37, Medicare. Medicare came into being under the Great Society legislation when Lyndon Johnson was president in the 1960s. He came and pushed for Medicare because he said there's something wrong in our country when people that work their entire lives and help build this country and make it a great country would retire and couldn't have health insurance. So he came out with a program called Medicare. And the Medicare program was broken down into certain parts. Initially, it was Part A and Part B. One was for inpatient hospital care. One was for outpatient hospital care. Then, and that's funded through the FICA tax. Then, in the 1990s, they came up with the additional tax for Medicare. And what you have to also remember is Medicare, for most people, would be for people over the age of 65 when they're retired, with certain exceptions. One being if you're a dependent on your own and need extra medical care. Another care would be if you have end-stage renal failure, which means you're in kidney dialysis, you'd qualify. So people collecting Social Security disability benefits also qualify, and disabled widows or widowers over the age of 50 would qualify for Medicare. Medicare Part A in 2013 has certain deductibles, and it says, and Medicare Part A is paid for, automatic, is part of your Social Security benefit. Remember that if you're not 65, even if you're retired, you don't qualify for Medicare. Let me say it again. If you're not 65, even if you're retired, you don't qualify for Medicare. So if Jill is 67 years old and Jack is 64, Jill is under Medicare, Jack is not. Medicare, and you don't worry about memorizing these numbers, except the concept is what I would need you to be aware of. The first 60 days of being an inpatient hospital, you will pay a deductible of $1,216 in 2014. Renewable period following 60 days, not in a hospital or nursing home. So if you're out of it for another 60 days and then you have to go back, it starts all over. The next 30 days of inpatient care, the Medicare will pay for the hospitalization minus $304 per day. And then after another 60 days, there's a minus $90 a day. Lifetime reserve days are non-renewable. So once you use them, they're gone. And the other thing is, what this really means is you're not getting full coverage under Medicare, which is why most people under Medicare, in addition to paying the Medicare premium for Part A, take Part B and take Medicare supplement policies on their own. Don't get hung up on the premium amount other than to know that it's graded and structured so the more money you make, the more it's going to cost you. And if you're not fully eligible for coverage under Medicare Part A, you're going to pay a premium. Most people at age 65 don't pay a premium for Medicare Part A, but as you see at the bottom of the slide, if you have less than 40 quarters or 40 units, you're going to pay a premium. And it further says under the law that since 2013, if you're a higher income earner, you're going to pay a higher premium. And higher income here says most people are going to pay $104.90 for Medicare Part B, but if your income's over $85,000 as an individual or over $170,000 as a couple, you're going to pay an additional $146 for a grand total of like $251. If your income is higher still, that amount's going to increase to $209 and or $272 and change. And if you're higher still, it's going to go up a third time. So remember, Medicare premiums are graded based upon your income. Medicare Part B will cover you for $104.90 per month, and that's going to cover certain things that Medicare Part A doesn't cover and a lot of your deductibles. Slide 42. Medicare Part A will cover you in a skilled nursing facility for up to 100 days. Many people believe incorrectly that Medicare Part A, Medicare covers nursing care unlimited. It only covers you in a skilled nursing facility for up to 100 days. And the last study I saw, which I think was in 2006 or 7, the average length of time Medicare paid for patient coverage was about 26 days. And someone says, well, why only 26 days if it says here they'll cover up to 100? That's because if your total benefit, if you're not progressing, if you had a stroke and you're not making progress on physical or occupational therapy, or you broke your hip and you have Alzheimer's and you can't do the therapy, you're not making progress, they're not going to pay under Medicare to keep you in that facility. You're going to have to go to a private pay situation because things are changing. Medicare Part A says we're going to cover you for unlimited home care visits if it's ordered by a physician. We're going to cover you for blood transfusions after the first 3 pints. I don't know why 3 pints is deductible. It's going to cover you for hospice care. Hospice care is very expensive end-of-life planning, but it's usually very, very good. Slide number 34. Medicare has some restrictions on geography. If you do a lot of traveling, make sure you get travel insurance. Because it says here that only emergencies in Mexico will be covered, or Canada, or certain things on a cruise ship. So if you're retired under Medicare and you do a lot of traveling, you may want to make sure that you buy the supplemental insurance through the cruise ship or through a travel agent. Medicare is designed to be a secondary payer. So if you have any other insurance policy or you have any other governmental benefits such as veterans or workman's compensation, that will become the primary payer. Medicare will become the secondary payer. Many people think Medicare covers everything. It's not designed to do that. Medicare Part B, again, It's $104.90 per month for most people. And that means you're going to pay a $147 deductible, and you're responsible for 20% copayment with no stop loss. So if your bill is $70,000 and you only have Medicare Part B and Medicare Part A, you're responsible for 20% of that $70,000, which is why you really need to make sure, as a risk management tool, your clients look at Medicare supplement plans. And I'll be discussing that shortly. Medicare Part B also provides for coverage for office visits, diagnostic testing, transfusions, limited mental health benefits, and so forth. What's not covered? A lot of things. Now, some of this is going to change under the Affordable Care Act, so I want you to update this. I can't give you the specifics because I'm not sure it all kicked in yet. Under the Affordable Care Act, routine exams and exams for eyeglasses are going to be covered. Hearing aids may or may not be covered, I don't know. Routine trips to podiatrists are going to be covered, and right now, under the Medicare plans, these are things that are excluded. Under the new Affordable Care Act, they're probably going to be included. Slide 49, Medicare C is what's called Medicare Advantage, which is like a PPO, an HMO for Medicare plans. A lot of companies stopped selling them in the 2000s because they were losing money. I don't know, in Cook County, I don't believe there are any. There may be some in some of the collar counties, but it was a kind of plan that functioned like an HMO. You had a lot more benefit as long as you didn't travel away from your area. And just as though you had the HMO and you had the benefits, you have to be aware of the fact that you had, it was like an HMO, which meant you had preventive care and you had lower fees to you, but that also meant you may not have the same choice of doctors. Medicare participants can enroll in the drug program. In hospital, you did have drug benefits. Out of hospital, you didn't. Very controversial. I don't want to discuss the politics of it. A lot of people are upset about the fact that Medicare has an upfront deductible. You pay a premium right now of about $32 a month. You retain the first $300, $310 of expenses, and after that, they're going to pay 75% of the next $2,840 until you hit what's called the donut hole, and then they pay nothing until you've gotten to your maximum. So people are upset about it, but again, you're not going to get tested on anything other than remembering that Medicare Part D is for prescription drugs outside of the hospital, and it covers it with certain restrictions. This is a highlight of what I just told you, that the premiums increased over 2014 from 2013. Slide number 42, Medicare Part D subsidies. If you're a low-income senior, you can apply for Medicaid and/or subsidies from your own insurance. Medicare under Medicare supplemental plans, sometimes referred to as Medicare Sup or Medigap insurance, would cover a lot of the things, ladies and gentlemen, that Medicare Part A and Part B don't cover, would eat up a lot of your deductibles. If you have a Medicare Advantage plan, they work nicely to make sure you have even more benefits. However, you're going to pay for this. And Medicare supplement plans are standardized. So anybody that has a Medicare supplement Part F, all the F plans are the same. All the G plans are the same. All the M plans are the same. It's how much the insurance company can charge depending on what they believe to be what they want to have a profit on. So Blue Cross, ARP, Aetna, Cigna, American Medical Security, Continental General, all of these companies have Medicare supplement, and they can charge whatever they want, but all of the F plans have to have the exact same benefits. So the consumer will decide what plan they want to be under. Slide 45, this is a change in the law. Be aware of it. Prior to 2014, you could deduct medical insurance and expenses if your adjusted gross income if those expenses exceeded 7.5% of your adjusted gross income. As of 2014, that is now 10% of your adjusted gross income, unless you're a senior, which until December of 2016 is still at 7.5%. Benefits received individually issued medical policies are generally not subject to income tax. Managed care plans, I'm on slide 47. They address both delivery and cost of care. They're called health maintenance organizations, preferred provider organizations, point of service organizations. Each of these have their own kind of plans, the way they handle things, and we're going to discuss each of these in a little detail right now. HMOs are basically plans that are preventive in nature. They started after World War II, mainly with the big unions, the United Auto Workers, the United Mine Workers, where people would have many children and not want to go to the doctor because they didn't have the money. So under health maintenance organizations, they would get all kinds of care. They'd get well care, they'd get immunizations, but the doctors in the plan would get a flat fee for each family or each individual that's covered per month. Whether you went to the doctor or you didn't, they still collected the same fee. That's called a capitation fee. Doctors became gatekeepers. So if you had a general practitioner under an HMO, you need to see that person to get a referral to a specialist. Women under HMOs and under point of service plans and under some PPOs, we have a primary care physician, general physician, and a primary care OB/GYN, so they can get the exams they need on demand without going to a second step or stage of a doctor. One of the big limitations of HMOs is if you do a lot of traveling or you're not in the network, you may have no coverage. That the law says that if you have a life-threatening emergency, they have to cover you, and then they can stabilize you and move you back to an area of your own location where your coverage is there. The other thing is if you were skiing in Vermont and were in an accident, if it was non-life-threatening, they'd stabilize you and send you home. If it was life-threatening, they would obviously have to take care of it. Slide number 60 discusses PPOs, which are preferred provider plans. These are the kind of plans where doctors would contract with the insurance company, hospitals would contract with the insurance company. The insurance company said, we're going to send you a lot of our business so you're going to get a lot of volume, but we want you to give us discounts. That's what PPO stands for. They pre-negotiated what they're willing to pay. Point of service plans, POS, is a cross between a PPO and an HMO, where doctors would have a doctor's copay for the office visit. You'd have a primary care physician. That doctor's copay could be $25 or $50 per visit, and that's all you'd be responsible for, just like an HMO. You'd be able to go for well care without having to say that you had a stomach ache, and they are somewhat popular because of that. Oops. If you're with a large company, they may self-fund the insurance and hire a third-party administrator to cover that. And they may have major medical plans, PPO plans, HMO plans. And what the big advantage is, we've talked before, is you're not paying the premium tax to the insurance company, and you're not paying the administrative fees. You have to outsource that yourself. Pay attention on self-funded plans, the fact that you don't get to deduct the money that you put into the escrow account or the reserve account until you spend it. Unlike a health insurance plan, you get to deduct the premium as it's earned and paid. Employers may deduct the cost to provide health care coverage. The employee is not taxed on that premium currently. That's going to change. Savings accounts. If you get a test question on an Archer Medical Savings Account, there's no such thing. The Archer Medical Savings Account was a pilot program that started in the late 1990s and I think expired in 2005, but there still are plans on the market and they're allowed to continue. They function the same way and very close to the health savings account. But again, if you get a test question on the medical savings account, it's not the same. This next slide, number 55, gives you the general features of the health savings account. You set up a health insurance plan. It's called a high deductible plan. Not every high deductible plan qualifies. It has to say there's a high deductible plan that qualifies for the health savings account. Blue Cross, as an example, sells a $2,500 deductible comprehensive plan, does not qualify for the health savings account. They also sell a $2,500 deductible that does. You can set up your own side fund, like an IRA, and put money in on a tax-deductible basis. That money grows income tax-free if you use it for medical expenses. If you use it for non-medical expenses, you're going to pay a penalty that just went from 10% to 20%. So if you use it for non-medical expenses, the penalty now is 20%. If you have money in the account, it's not like a flexible spending account where you need to use it or lose it in the same calendar year. If you have money in the account, yes, I should not have sat down on the desk. If you have money in the account, the money can be transferred to a beneficiary with no taxes, and you can use it 2 or 3 or 4 years later. I've seen people set up a health savings account, put money in, never touch the money, and 2 years or 5 years later use it to help pay for orthodontia for their children. The health savings account, you don't have to memorize the numbers other than you have a maximum amount that you can deduct as an individual of $3,300 a year in 2014. As a family, it's $6,550, but notice the catch-up provision. For an IRA, a 401k, or 403b, the catch-up provision starts at age 50. This plan, the catch-up provision doesn't start to 55. And the catch-up provision is only good for $1,000 extra. So be aware of that. Catch-up provision starts at age 55. Slide number 57 is the maximum out-of-pocket exposure for an HSA in 2014 is $63,750 for an individual, $12,700 for a family. Slide 58, again, you will not lose money if you put money into the health savings account and don't spend it in that same year. It's flexible in that you can keep it. You can even keep it to retirement, and at that point use it to help pay for Medicare supplemental long-term care premiums. Note that the 10% penalty on taxes, if you use the money, actually it's wrong, it's 20% now. For some reason that slide's incorrect, it's 20% if you use it for non-medical expenses. The medical savings account has the same kind of benefits, even though they're not being sold, but there are plans on the market. It has the same kind of benefits and limitations. I'm going to take a break and then come back and talk about disability income. Welcome to the third session for the 5th of March, unit number 9. This is session 11. Now we're going to be talking about the economic risks of disability to the individual. And the truth is, disability is one of the most underserved and underutilized areas for insurance and financial planning. If we have 35 or 40-year-olds, the chance of being disabled for 90 days or longer for an extended period of time prior to age, which is an extended period of time, prior to age 65, or let's call it retirement, is 7 times more likely than that same 35 or 40-year-old to die. And it says that what is the impact on disability for all of us? Well, most people today are working because we need to. We need to pay our bills, we need to pay our student loans, our mortgages, our car payments, put food on the table, take care of our children. Most people work because they need the money. And in today's world, we have less and less corporations that allow you to roll over your sick days. And in many cases, where people used to have a sick day a month, now they're lucky to get half a sick day a month. So 6 days might be the maximum a year. In some cases, it might be 10. And in most cases, you can't roll over more than 2 or 3 from 1 year to the next. Many firms don't allow you to accumulate vacation time. So you don't have that big buffer of time, and you don't have the sick days to help you. If you're disabled and you don't have any kind of protection, what do you do to pay your bills after 30 or 60 days? Your bills don't stop. Your mortgage company doesn't say, well, you're sick, so we're going to give you a break. Your student loans don't stop because you're sick. So you have to figure out a way to do this. If you died, most people have life insurance. But disability insurance is an important consideration as a risk management tool for financial planning. What you have to be aware of is the terminology. You're not going to get test questions asking you what is an elimination period. You're going to get a situation to see if you understand it. The good news is the elimination period for disability income and for long-term care insurance is the same. It means the same. The benefit period means the same, and the benefit amount. So what you have to be aware of is once you understand the terms, it's going to hold you in good stead for both kinds of insurance. Elimination period means you're self-insuring the period of time. You don't have any coverage during the elimination period. What you have is a period of time where you have no insurance. So it says here, if Jack is disabled on January 1st and has a 90-day elimination period, when should he expect to receive his first check? Well, think about this. A lot of people would say January 1st, February 1st, March 1st, so somewhere around April 2nd or April 3rd. That's not the right answer because he has no benefits at all. Nothing is accrued during those 90-day period. That's his elimination or self-insurance or deductible. A 60-day elimination period would mean you have no benefits for 60 days. Nothing starts happening until after you've gone through that elimination period. So when you look at the term, the question becomes, how long can you afford to sustain yourself? Now, my personal belief is I will take a longer period of disability or long-term care and self-insure it, and I'll take a higher deductible on my auto or my homeowner's policy because if I don't have a claim, I'm going to save money on the premium. I'm not concerned about the first $1,000 or the first 1 or 2 months of bills. I'm concerned about month 30, 35, 50. So that's what I'm concerned about is a catastrophe. And that's how I explain it to my clients. The longer the elimination period, which is the period of time that you're self-insuring or your deductible, the lower the premium. I'm not suggesting for most people to get longer than a 90-day elimination period because that means that they may never use the plan, but more importantly, they may not be able to afford to sustain themselves for that period of time. The textbook would say take a longer elimination period to keep the cost down, but then analyze the client's situation. If your client is a doctor, an attorney, a CPA, a financial planner where they have accounts receivable, they could probably afford a 90-day period to sustain themselves. Teachers, governmental employees could usually take a 90-day elimination period because they can accrue those sick days and let them stay in their sick day bank for a long period of time. Most workers today can't afford that. So you may need to think about a 60-day or even a 30-day elimination period if you can afford it, realizing it's more expensive. The next piece is what's the benefit period? The benefit period is that length of time that not that the policy is in force, but the length of time that you receive the benefit. So if you have a 90-day elimination period with a 5-year benefit period or a 60-month benefit period, that elimination period says you were disabled on the 1st of January. 90 days later, about the 2nd, that's all of January, all of February, all of March, you start getting your accruing benefits at the rate of 1/30th per day, about the 2nd of April. Let's assume you have a $3,000 a month benefit. That's $100 a day. Every day you're disabled after the 2nd of April, you accrued $100 of benefit. If you have a 5-year benefit period, that doesn't mean you have a policy that's only in force for 5 years. That means that once you go on benefit, once the benefits start, it will go for a maximum of 60 months. And if you get better and go back to work, usually it will reset after 6 months or something to put those benefits back. So you have to remember slide number 70, on this example, slide number 61, it might be a little different in your text, in your workbook. On this example, remember to understand the term elimination period. You're self-insuring it. It's a deductible. The benefit period is the number of months that you have the benefit for. The benefit amount is how much you're going to get paid. What's also very important is what is the definition of disability. You don't want a definition that says you're disabled if you're in a car accident going west on the Eisenhower Expressway in Chicago on the second Tuesday of any month between 10 a.m. and 3 p.m. if you are east of First Avenue and west of downtown. That's a very restrictive definition you'll probably never collect. Social Security has a very restrictive definition. Social Security says that you're disabled if you're unable to do any kind of gainful employment for which you're suited. That's very restrictive. The only kind of plan that can use that definition is Social Security. The definition of total disability found in public plans that are purchased by insurance companies, whether group or individual, is what you're really buying. And make sure you understand what you're getting. You want your client and yourself to have what's called an own occupation definition, which says you are disabled if you are unable to do the substantial or important or main duties of your occupation with regard to education, training, prior work experience, and economic status. Why is that important? If you're trained as a cardiac surgeon and you're working as a cardiac surgeon and you become disabled, you get arthritis in your hand, you can't hold the instruments. Can you still teach at a university? Sure. Could you teach to college? Probably. Could you teach surgical skills? Maybe or maybe not. Would you make less money teaching than you would as a surgeon? Probably. Therefore, the term economic status means I'm trained as a doctor, I can do all kinds of things as a medical doctor, I'm qualified, my education, my training is not only as a doctor, but as a specialist in cardiac surgery. So that's education, training. I've been doing it for the last 5, 10, 15 years, work experience. So economic status is how you're going to get paid. Even if you can function as a doctor doing something else, you're still able to get paid. Now, many insurance companies are getting away from the traditional own occupation of disability and getting rid of the term economic status because they have to keep the premiums down and trying to maintain their programs without going broke. So a lot of companies now say education, training, work experience. That's not as good as with economic status, but still not bad. In many cases, insurance companies are going through a split definition, which says, slide number 65, for the first 2 years, 3 years, 5 years, maybe for the first 10 years, we're going to use that traditional definition, education, training, prior work experience, and economic status to determine if you're disabled. After that period of time, we're going to say if you're reasonably suited to do this. We're going to get rid of that economic status. Most group plans use this kind of a definition. Some plans are going what's called a dual definition, and that's where it's on slide number 66. Irwin was an oral surgeon. He severs the thumb on his and forefinger in one of his hands. He can no longer be a oral surgeon. However, for the first 1, 2, 3, or 5 years, he will get paid. After that, can he teach surgery? Can he teach dentistry? Can he write? Can he be a consult? All of these things are important. The definition is key to what you're buying. And that's why if you're reviewing policies as a risk management tool as part of a financial plan, if you don't understand how to look at it, find a professional you can work with and have that person help you and analyze it for you. I've already discussed slide number 67, which is the traditional definition for Social Security, which says the inability to work in any gainful employment for which you could be suitable for. So this definition says you are the oral surgeon, the cardiac surgeon, the CPA, the financial planner, but now you can't do that, but can you be a greeter at Walmart? Can you sit on a telephone and answer a phone for somebody? Then you're gainfully employed. The Social Security definition of disability is not allowed in any kind of commercial plan. For you to collect under Social Security disability, it says that you must be so impaired that you will probably never recover or will result in your death. Your impairment must last a minimum of 5 months before you can apply. It has a 1 year, in many cases it has a 1 year waiting period unless your impairment is so severe that they will verify you'll still be disabled in a year or result in your death. And it also will be offset by other governmental programs such as veterans or workmen's compensation. So if you're covered under something else, Social Security doesn't have to pay. Most private plans and a lot of group plans offer what's called presumptive disability. Presumptive disability says if you lose the use of your hands, not necessarily severed, but the use of your hand, the use of your feet, the use of one arm, one leg, one foot, one hand, your speech, your hearing, or your eyesight. It doesn't say you have to lose your eyes. It doesn't say you have to lose your ears. If you just lose the use of it, you're presumed disabled. When I was on one of the exchanges, a friend of mine lost his voice, and he basically talked like this, and he was at a disadvantage in a trading pit with a couple hundred people loudly screaming to buy and sell. Had he had disability income insurance, he would have been considered disabled. I knew people that had rotator cuff surgery, and they were able to collect for 3 months, 6 months, 9 months during that period of time because they had the right kind of disability income policy. I had a dentist who developed arthritis in her hand, and she was able to collect under a long-term care policy with own occupation definition for many years, even though she was able to teach part-time at a university. Some disability income plans offer what's called loss of income. And here the example is Marie was earning $100,000 a year. She became disabled. Now she can't work full-time. She has a $40,000 income. They're going to pay her 60% of the benefit. Some policies have other kind of benefits to offset things. So you have to be aware of what it means and what it says. Earlier when we talked about health insurance, there was a clause that talked about different definitions of the kind of plan you would have. I'm now on slide 71. And it said, what does non-cancelable mean? Non-cancelable means that should you have a plan, a disability income plan, the insurance company cannot cancel the plan, they can't change the definitions, they can't raise the premiums as long as you pay your premium when it's due, once it's in force. Non-cancelable is more expensive than anything else, but you're buying the Cadillac plan. If your clients can afford a long-term disability non-cancelable plan with own occupation definition, that's the best thing to get. Guaranteed renewable says, we, the insurance company, will guarantee to renew your policy as long as you pay the premiums from the day it starts. However, we have the right to modify the premiums. We have the right to change some of the definitions or even review it. If you change your occupation to a more hazardous occupation, we can modify the plan. We can even say, verify your income was still where it was. Guaranteed renewable says we have the right to guarantee renewing it. We're not going to cancel it, but we can make changes. Non-cancelable says we can't make any changes. Conditionally renewable, I've only seen this once or twice with some very high income earners where the company said, we're really concerned about substance abuse, alcohol abuse, mental illness. So they said every 2 years we're going to re-underwrite it. Now, but understand the person was getting a benefit of $15,000 or $20,000, $25,000 a month of coverage. I've already discussed the waiting period. Typically, Most plans are going to have a 90-day elimination period. Some of the older plans might have a 30-day. A lot of times I will talk to people about maybe a 60-day elimination period. The maximum benefit period, I'm typically asked what this should be. And I will tell you, I don't know the answer. Statistics tell me that the average person that's disabled, whether it's an illness or an injury, will be fully recovered within 24 months. Maybe 85 to 90% of the time. However, if you fall into that 10 to 15% where you're not fully recovered, there's about a 95 to 98% chance that you'll still be disabled past 5 years. So how do you want to look at it? Many times for long-term disability, it's a budgeting issue. So I will look and say, let's go for a 5-year benefit period. I prefer one to age 65 or to retirement, but let's go to 5-year benefit period just so you have the plan. Many times I'll suggest, depending on the amount of time and the budget, I may agree to a 2 or 3-year benefit period. I try not to, but you have to weigh one against the other. I want the best definitions and the best plan on the definitions. So sometimes in order to maximize it, you have to adjust certain other programs so at least you have something. I've already discussed how the benefit is based on a percentage of salary. Now this says, the textbook I believe says they go up to 70-75% of salary, which isn't true. Most insurance companies today will underwrite somewhere between 50 and 66% of your wages. So that if you're making $100,000, you figure that after you pay your taxes and FICA taxes and maybe state withholding taxes, you're netting out maybe 60%. So they're going to underwrite you for $5,000. If you're a lower income earner, maybe you're only making $45,000, they may underwrite for 40%. They don't want to make it too attractive for you never to go back to work. If they would underwrite the full salary, including taxes, you have no incentive to ever go back to work. And if we're going to talk about, when we talk about group plans and who's paying the premium, you're quickly going to see that you always want to be paying some of the premium, because if your employer has a plan and the employer pays all of the premium, when you get the benefit, it's taxed as ordinary income. If you pay, even on a group plan, you're paying extra compensation on 1099 or additional compensation on a, I forgot the word, your W-2, then if you can substantiate it, then it's income tax free. Now why is that important? Well, if the group plan says we're going to pay up to a maximum of 60% of your salary, to a maximum of $5,000 a month, and it's all taxable. They've already taken off some of the money because of the definitions. Now they're taxing you on what's left. You're walking away with maybe 35% of what you used to make as opposed to 60%. If you look at the textbook, it talks about partial disability. In today's world, partial disability means you were never fully disabled. You may have had a broken leg, you may have had a heart attack where you could only work 2 or 3 days a week. That's partial disability. So the insurance companies want you to work. They want you to be productive. It's healthier for you in the long run. So they will say, we'll pay you a percentage of your income. So in this case, if you're losing 50% of your income, we'll pay you 50%. If you're losing 2 days of work on a 5-day work week, we'll pay 2/5. So they're going to, or 40%. They're going to make sure they can help you out. Residual disability, by definition, says after you've been fully disabled, if you go better and go back to work, you get better and go back to work, you can't work full time, we will pay you that percentage until you can go back to work full time, as long as you've had a 20% or greater loss of income. Slide number 77, just like future purchase option for life insurance, you have the right to buy more disability insurance at given ages, as long as you can verify your income is higher. even if your health has gone down. And quite frankly, I've seen that happen many times where people in their 20s or 30s will buy a policy. The last benefit might kick in at age 40 or 42, and by then they've had a medical situation, but they can still buy additional coverage. Just as gasoline and milk and your mortgage and your property taxes go up, you want cost of living adjustment that says your benefits will go up based upon 3% or 5% or an inflation factor while you're getting the benefits. Some policies have, on slide number 79, have what's called Social Security substitute. Here it says you have your base benefit that you're paying for, that's $4,000 a month. Your Social Security benefit is $1,000 a month, maximum. You're getting $500 from Social Security. So that's going to be in addition to your base benefit. So you're not getting a haircut because of Social Security. If you qualify for Social Security, you're getting some extra money. Now, there are some older plans on the market where if you had a rider and you received Social Security, they would deduct the money from your benefit to keep your costs down, but I haven't seen a lot of those recently either. Slide number 80. It's important for you to remember that if you pay for a benefit for long-term disability with after-tax dollars, if you pay for the benefit with after-tax dollars, you will not be charged taxes when you receive the benefit. Part of that reasoning is you're already getting a haircut of 40% for the benefit. Part of the reasoning is that it's your after-tax money that's buying the insurance. That's why if you have a benefit at work, make sure you're paying some of the premium, and they will give you a 1099, and most companies that offer the plan do require you to pay some of the premium. If you are a partnership or a greater than 2% shareholder, depending on how your business is set up, you can deduct the premium as an employee benefit. If you're in a S corporation, it's pass-through income. It really doesn't work the same way. Disability income, you can be somewhat selective. My understanding is you don't have to include everybody on a disability income plan in order to have it pass muster. Group disability plans, some are long-term, some are short-term. Short-term would be less than a year, maybe 26 weeks, maybe as little as 13 weeks. The long-term disability income plan is what's really important because that's what's going to keep you in your lifestyle. And for most long-term plans, where it says 20 days, in all honesty, what I'm seeing in the marketplace today is 30, 60, 90 days. There are some companies that offer a 180-day elimination period. I'd never recommend getting it because even though the premium is low, you'll probably never collect. It is a very important piece of planning for people. Slide 85, I've already discussed all this a couple times. Slide 86, if you have more than one plan, most group plans reduce benefits to correspond with Social Security. Once you qualify, most private plans give you the benefit in addition to Social Security. So that is the overview of disability income. You have more information in your textbook. I'm going to stop the recording for a couple seconds, and then we'll reconvene with long-term care planning. Welcome back. This is Howard Sorkin, re-recording from Wednesday, March 5th. This part of the unit number 9, session 11, long-term care planning. Long-term care insurance is increasingly becoming a very important part of clients' risk management profiles, especially as we're getting older and living longer. Most couples at the age of 65 have a 40% chance of needing extended care either at home or in some kind of facility for 90 days or greater prior to dying. The older they get, the longer they live, that percentage goes from 40% to 50%. Once they're in their 80s, that percentage is above 75 to 80%. If you go to any kind of facility, you're going to find that most people in the facility are women. Women are the natural caregivers in society. Women are the people that have taken care of their spouses, their husbands. And in some cases, after they've gotten divorced, women have gone back and taken care of their former husbands. Just because people are talking about long-term care in their 60s and 70s doesn't necessarily mean that you may not be afflicted with a injury, illness, broken hip, or cognitive impairment in your 40s or 50s. So it's increasingly becoming a very important part of planning. Long-term disability helps you to provide additional income when you're disabled. Long-term care insurance provides the additional expenses, money for the expenses of staying in a facility. Nobody, underline the word nobody, wants to go to a nursing home. Nobody wants to be in a skilled nursing facility. If you've never visited them, trust me, just go and make some appointments and go see them. The first floor is usually a very lovely place. It looks nice. They have flowers and everything's fine. The rehab floors are okay. And then as you get into the building to different places and the longer care and the more health critical issues, healthcare issues, things change. No matter how nice it is, there's always some kind of an odor. You get on the dementia floors and it's somewhat depressing. And I will tell you, having visited them for many years and more than one facility, you never sit down on any kind of a chair without plastic or a newspaper because you don't know what's been on that chair, especially on the dementia floors, before you sat down. It says here that nursing home costs exceed $100,000 a year in many parts of the United States. In the Chicago metropolitan area, the average cost right now is about $6,000 a month, $72,000 a year. Let me say that again. The average cost in the Chicago area is $6,000 a month. If you look at a chart for the entire state, that cost might be down at around $150 to $160, but that includes far southern Illinois, where it might be $100 to $110 a day, to the northern suburbs, the Oak Brooks, and the Gold Coast, where it could be $350 a day. When we're talking about the average cost of $72,000 a year in the Chicago area, that is mainly room and board, double occupancy. That is not including disposables, toothpaste, having your hair taken care of, and other expenses. And be aware of the fact that home health care is not that much cheaper, if in many cases more expensive, than being in a facility. The average long-term care patient, the average person in a long-term care facility, is paid for by Medicare and or Medicaid. About 8 to 12% will be paid by private insurance. Maybe as much as 20% will be paid by out-of-pocket until people run out of money. And the rest of it, 50 to 60%, is paid by either Medicare or Medicaid. Medicare covers up to 100 days lifetime benefit for skilled nursing facilities only. However, as I said earlier in this session, the average length of time in 2007, I think it was, that Medicare would pay for was about 22 to 27 days, because under their regulations, if people aren't getting better and they're not making progress, Medicare stops paying. And it happens more and more frequently. The actual cost, depending on where you live, would determine what you need. And the cost, if you have clients that are going to retire in another part of the country, they should do some research and find out what they're going to need for that cost. And don't always assume that the cost is financial. If you are taking care of parents or grandparents or other siblings, friends, relatives, there's a physical and emotional cost involved. And there's a lot of time involved. My mother-in-law was in a nursing home for about 9 years with Alzheimer's. My wife and or myself would go there 3, 4, 5 times a week. When someone has Alzheimer's, a 10 or 15-minute visit's a long time, but we'd constantly be checking up on her. We had somebody else. I had a cousin who would spend a couple hours a week putting pills in the pill boxes for his mom and dad, and then you take people to their exams. You always have to take your older loved ones to exams to the doctors because they can't get there themselves. In many cases, you have to sit there and take notes and make sure you know what's going on. So there is a cost involved, and it's not just economic. When you look at policies today, since 1996, under the HIPAA legislation, also known as the Kennedy-Katzenbaum bill, the government said, we are going to standardize what would be covered and how things will be covered for long-term care policies. Prior to this law, some insurance companies said you have to qualify by being unable to do 5 of 10, 4 of 8, 6 of 9 activities. Now the law says if you are unable to perform 2 of 6 of these activities, you're considered chronically ill, chronically disabled, and the policy will pay, and Medicare will pay. Cognitive impairment is an automatic trigger. So let's explain what this means. Think about what you do the first 20, 30, 40 minutes every day when you get up. What do you do? Well, you wake up, and if you're healthy, you can transfer yourself by getting out of bed, walking, going to a chair, getting back into bed, getting into a chair. That's transferring. You get up, you walk. Most people, the first thing they do is they're going to go to the bathroom. Well, toileting means, can they physically get on and off the commode? Do they have the ability to do that themselves? Continence says, do they need a diaper? That's a little different than getting on and off the commode. Do you need a diaper? And unfortunately, many people as they get into their 80s and 90s do. Can you feed yourself? It doesn't say can you make your own meals. It says can you feed yourself? Can you dress yourself? And I have seen people with very bad arthritis where they have Velcro as opposed to buttons and zippers. But they can dress themselves. Can you bathe yourself? Can you get in and out of a shower? Can you sit on a stool and give yourself a bath or a shower? Do you need help? If you are unable to do 2 of these 6 items, that would qualify you for being coverage for long-term care. Cognitive impairment is critical today, especially as we get older, but don't say it's only for the older person, because one of the major insurance companies has actually spent money on claims for somebody at 39 or 40 years of age for Alzheimer's. So Alzheimer's is not excluded under HIPAA. It's no longer allowed to be excluded. And whether it's Alzheimer's or dementia, cognitive impairment, if that's certified by your doctor, which means maybe you can't communicate, maybe you can't remember, maybe you can't use the phone, maybe you can't look at a picture or a clock and say, when is it 2 o'clock? Basic things that you remember doing from the time you were in kindergarten and 1st and 2nd grade, if you can't do it, that's cognitive impairment. So cognitive impairment is an automatic trigger for benefits. Otherwise, it's 2 of 6 of the activities of daily living: bathing, dressing, eating, maintaining continence, toileting, transferring. 2 of 6 that would trigger it, or cognitive impairment. What's going to be covered? There's different kinds of plans. Now, if you're under Medicare or Medicaid, for the most part, you're only going to be covered in a skilled nursing facility, which means they have registered nurses, they can do therapy, they can draw blood, they can maybe take x-rays, skilled facilities. Intermediate care has less skilled facilities. They may not have all those abilities. Custodial care is mainly you have help, assisted living, but we have to define assisted living, ladies and gentlemen, a little differently. Assisted living doesn't mean that you're living in one of these retirement communities where they make your meals, take care of your room, and they have social activities. Assisted living means you need help with the activities of daily living. Many people believe that staying at home is cheaper. If you need enough care, it really isn't. I can tell you that firsthand experience. I can also tell you that the older policies, if you had a $200 a day benefit on an older policy for home health care, you'd have a $100 a day benefit. That's not really what you want. In today's world, you want the same benefit. Now, some of the terms are identical to what we just talked about for long-term disability. Elimination period. You're self-insuring. You have no benefits until you get through the elimination period. Most elimination periods are 30 or 60 or 90 days. There are companies that offer longer. I wouldn't recommend it because even though you're lowering the premium, you may never use it. The $100-day benefit would dovetail with Medicare if Medicare will pay for the 100 days. And it says you still have to pay those dollars out of your pocket during the elimination period. Some of the newer policies offer a home health care provision that if you use their certified skilled care coordinator, which is a registered nurse, to make sure you're getting the benefits and the care you need, and especially in today's world where your children may live in another city or another state, there's someone to sort of monitor and make sure that the person's getting the care and you're not being abused. Elder abuse is a big issue today. So if you use their care coordinator, a lot of times that 90-day or 60-day elimination period for home health care becomes a week. Long-term care benefits usually start at 2 years, where it says to lifetime. Most insurance companies today don't go longer than 7 or 8 years because they can't afford to price it. The longest claim I've heard about is about 14 or 15 years from one of the major insurance carriers, but most plans offer 2 years, 4, 3, 4, 5, and 7 or 8 year benefit. People say, how long do I need the benefit for? Tell me what study you want to believe. Let me explain. If you believe one study, the average length of time is under 2 years. That is true if you're in your 80s when it happens, or if you went to a nursing home end of life, be a terminal something. If you're in your 50s, 60s, it might be 10 years. So depending on whose study you want to believe, I've seen 39 to 52 months as an average. So when I'm talking to clients, if they can afford it, I always want them to look at maybe a 5-year benefit period. If they can't afford it, I'll cut it back to 4. If they can't afford 4, I'll cut back to 3. I don't want to go below 3 because then the averages are working against them. Under the law, long-term care protection has to offer inflation protection. That doesn't mean you have to buy it. But now people have to be offered it and you have to explain it to them because 10 years ago, the average cost in the Chicago metropolitan area is about $150 a day. Today it's at least $200. So if you had 5% compounding, at $150 today, 10 years later is probably around $240 of benefit. It's kept pace with inflation. A lot of the companies today have gotten rid of 5% compounding and they'll offer 5% simple or even 3% simple or 3% compounding just to keep the premiums down. Most people that are buying their benefits today are in their 50s, early 60s because they see what's happening to their parents and their grandparents. And inflation protection will add to the cost, but you have to be able to explain it. And if your client is buying it and they don't want inflation protection, they have to sign a waiver saying that they understood it and they decided not to get it. It says there's no limit on benefits for long-term care. You usually buy it in $10 increments, and it says you can buy it up to $500 a day. Currently, plans that qualify under the Kennedy-Katzenbaum bill, which is called a tax-qualified plan, you pay no income tax on the benefit when received. The long-term care insurance underwriting is based on age, health history, your sex. Ladies, in newer insurance plans, women do cost more than men for long-term care because they use it longer because they've helped take care of their husbands for longer periods of time. It will look at your health history. I've already said that if you have a plan, I'm on slide 98, you're not going to pay income tax on the benefit when received. Please note, prior to 2014, if your total medical expenses, including these premiums, were at 7.5% of adjusted gross income, you could take the overage as a deduction. Now it's at 10%, but remember, if you're over the age of 65, until the end of 2016, it's still 7.5%. The chart at the bottom of slide 98 indicates that if you have at different ages, you can write off the amount of premium based upon what you currently have. Slide number 99 talks about qualified and non-tax qualified. In all honesty, there's a lot of policies issued before 1996, and even some issued since 1996, where they're called non-tax qualified. That doesn't mean you're going to pay income tax on the benefit, because the government has never come up with how they're taxing the benefit. So what it says here is, subject to the maximum per day, the amount in 2014, it's around $350 a day. So if your benefit's over $350, it might be taxed, but I've never seen anyone have to pay tax on it. Long-term care policies by law have to be at least guaranteed renewable, which means once they're issued, the insurance company cannot refuse to renew it as long as you pay the premium. Medicare, as I said earlier, the qualification is you have to have 3 nights in a hospital, and then Medicare will pay if you, let me back up. For Medicare to pay, you have to have been admitted to a hospital and be there for 3 nights. Many people today don't stay there 3 nights, even if they have a broken hip. The hospital will kick them out after 1 day, maybe 2. They don't want them there 3 days. And if they're not there 3 days, Medicare will not pay a penny for long-term care or skilled care. The other thing to be careful about, and there was a news story on NBC News, that be careful if you go to a hospital and you're admitted for observation, Medicare may not pay. So if you have loved ones over the age of 65 on Medicare, make sure that if they have to go to a hospital, they're not listed for observation. Medicare says we will pay for up to $100 days lifetime benefit for skilled care. And it says for conditions already treated in the hospital and likely to improve. So they're going to check to see if you have improvement. If you're not improving, and what the Medicare rule says is you've plateaued, they're going to stop paying. My mother-in-law had osteoporosis. Her hip broke. She fell. She had to have surgery. She was in the hospital for 4 days at that time. She went to a nursing home, skilled nursing home. The skilled nursing home had her under Medicare. Approximately 30 days after she was under Medicare, they called up my wife and said, we can't keep her under Medicare any longer because she no longer qualifies. She's not making any progress for recovery on the broken hip. Now, why wasn't she making progress under the broken hip for recovery? Because she couldn't remember to do the therapy because she had Alzheimer's. Didn't matter. She was no longer covered under Medicare. Medicare only pays for skilled nursing homes. Do not memorize these numbers. Just be aware of the fact that they pay 100% for the first 20 days, and then they pay all but a certain amount. This number changes year to year. Be aware, again, 100 days maximum lifetime benefit in a skilled nursing facility, not assisted living and not home health care. Slide number 104. Medicaid is not the same as Medicare. Medicaid is for indigent. Medicaid is for people that have no assets, and it says that if you have no assets, it's a co-funded, co-sponsored program between the federal government and the state. If you have no assets, you'll qualify. But what do you mean by no assets? In the state of Illinois, you have less than $2,000 in cash. You can have a prepaid funeral. You can have your wedding ring. The community spouse can still live in your house, but not buy a new one, and can still drive your car, not a new one, and you qualify, and you might qualify for Medicaid. Can't guarantee you will. It's all up to the state. Medicaid services provide, again, for inpatient skilled care, for long-term care, and if you're under their Medicaid health insurance plan, they will pay for home health care, for hospice care, for lab tests, and so forth. And it's also important that that you understand the look-back rules. Medicaid says that in the event you had assets, they're going to look at your tax return for 2 or 3 years before you apply. If they say you had a lot of assets, they're going to want to see where the assets went. And if they can show that you transferred the assets to another loved one or out of your name, they can say for 36 months, we're looking back, you still had assets, pay your own money. If you transferred it to a trust, they're going to look back 5 years. If they find out that you transferred the money and they put you under Medicaid, they can come after your state to pay back the difference. The Medicaid rules have gotten very strict because none of the states can afford it. Under the 2006 Deficit Reduction Act, the ineligibility for people owning homes with more than $500,000 of equity, granted in 2007, 8, and 9, it may have changed, but eventually that $500,000 would go to $750,000. So even if you had no other assets, but you had equity in your home of that amount, you would not qualify for Medicaid. And again, if they did pay and they found out you had the assets after you passed away, they could come after your estate. This has been an overview of long-term care planning, how it's paid. It is not meant to be 100% exhausted, but it's to give you the information you need for the comprehensive exam. There will be a quiz on health insurance, long-term disability, and long-term care. It will focus also on the taxation of the different benefits and the definitions, and then that will also be on your final exam in this course. Please remember, when you go to take the comprehensive exam, pay attention to what's under the Affordable Care Act and ask the review instructor, what are they currently testing? Because I don't know what they're going to be testing in a year. Thank you very much. This ends session number 11, which is on unit number 9, and we'll be back with session 12 on Monday the 10th of March.